Welcome to Discover You, an inspiring podcast exploring cutting-edge solutions to our everyday psychological challenges. We explore complex mental health issues and talk to professionals, experts, and renowned authorities at the forefront of transformative healing. Our mission is to educate and destigmatize, and to ultimately view mental health as a proactive quest for optimized living and equilibrium, rather than mere crisis intervention.
Welcome, everyone. Introducing your host, J.D. Kalmenson,
CEO of Montare Behavioral Health, one of the larger behavioral healthcare companies in Southern California. Today, we will be discussing the complex and often contentious relationship between medication-assisted treatment and total abstinence and addiction recovery. We will be examining the efficiency of both treatment models in terms of creating long-term sobriety for all age groups, creating meaningful lifestyle and behavioral changes, and managing emotional and mental health. We hope this discussion will become part of a broader conversation about advancing and reimagining the way we approach recovery. We're so excited to have with us three amazing, insightful guests who will be joining today's conversation. First, I'd like to introduce Dr. Timothy Fong. Dr. Fong is board certified in adult and addiction psychiatry and is a professor of psychiatry at the Semel Institute for Neuroscience and Human Behavior at UCLA. He's the director of the UCLA Addiction Psychiatry Fellowship, as well as the co-director of the UCLA Gambling Studies Program. Also with us today is Lowell McGregor. Welcome, Lowell. Lowell is the founder and executive director of Tailor Made Retreat, a nonprofit abstinence-based 12-step immersion program located in Portland, Oregon. Lowell has been in recovery from his own alcoholism and addiction since December 10, 1989. For the last 31 years, he has worked passionately throughout the Pacific Northwest 12-step recovery community and has brought meetings into prisons, detox facilities, and clinical treatment centers. Lowell has introduced hundreds of people to an abstinence-based design for living, which aims to achieve and maintain sobriety through providing peace of mind. Last but not least, please welcome Heather Hayes. Heather is the founder and CEO of Heather Hayes Associates. She's a master's level licensed counselor, board registered interventionist, and certifies a RISE interventionist. A veteran of the behavioral health field, she has over 30 years of experience working with the full spectrum of addictive disorders. Known as one of the country's most prominent authorities on these topics, Ms. Hayes is a coveted speaker on the national and international stage and has been published in numerous journals, books, and other industry publications. I'd like to begin by discussing our format for today's presentation. First, I will introduce our topic. Our guests will then have the opportunity to share their personal positions. We'll follow that with a Q&A session where each guest will have the opportunity to ask a question to their person of choice. Then I'll ask each of our guests a question myself, and finally, everyone will have a chance to offer their closing responses and remarks. Without further ado, let's dive right in. Relapse rates have long been dismal, with relapse for general substance use disorder at 40 to 60% and up to 90% of relapse for after opioid treatment. Something is clearly broken within our current treatment system. Yet times are evolving and we find ourselves serving a new generation of clients. While this generation is often depicted as entitled or selfie-obsessed, alarming data about their struggle with mental health reveals a deeper reality. The CDC has reported that suicide rates have nearly tripled in youths aged 10 to 14 in the last 10 years or so. And rates of depression and anxiety have been steadily on the rise for young adults as well. Recovery has always been a complex road, and our current treatment systems have struggled to help patients navigate. However, if we want to successfully treat current and future generations of clients, we have to examine which modalities can actually help us achieve the most successful patient outcomes. And as such, the purpose of this discussion is to advance the currently stagnant stage of this conversation about the future of addiction recovery. And we invite you to join us and engage in this spirited discourse, which will help us understand if we can reconcile medication-assisted treatment with strands of the AA treatment, and if possible, what would be potentially the best way to do so. So I would like to thank our participants for joining us for this very important and exciting topic. And if everyone is ready, I'd like to begin by having you share your personal stance. Dr. Fong, would you like to get us started, please?
I would love to, and thank you, JD, for inviting me on. And it's a pleasure to meet you, as well as Heather and Lowell on this amazing topic. I've been an addiction psychiatrist for 20 years, and I think this is absolutely the most exciting time in our field. We have at our fingertips and our disposal many different ways of achieving improved treatment outcomes, recovery. I like to just start with the basics. For me, my goal is to look for achieving healthy recovery. And I define recovery as a lifestyle comprised of sobriety, citizenship, personal health. It's not just sobriety. And when we get to this concept, and you said it earlier, the relapse rates are too high. I look at it the opposite. Our treatment response rates are actually very, very good. You said it. We know that when patients enter treatment and then they stay in treatment, about 40% of them will get better. It's the same rate as obesity, diabetes, asthma, and even cancer. So we have treatments that work. And it isn't just one treatment fits all. We have a wide variety of treatments. And many times people are surprised that I, as a psychiatrist, there are a lot of patients I have that I don't want on medication. A lot of patients, I think that medications actually make them worse. I took a pledge, an oath, first day in medical school, to do no harm. I think medications are not for everyone, but they are also a vital part of the recovery story. So I have a couple of really basic principles that I say to patients when they walk into the hospital or into our outpatient clinic seeking treatment for addiction and mental health. I'll say substances are things that change the way our body functions. Medications are substances that restore normal functioning. And that's so important because too often we dismiss medications as it's cheating, it's not full recovery, or it's actually making people worse. And that's true for some side effects. But when we use medications properly, they can handle the biological, psychological, and social changes that occur that allow recovery to happen. In other words, they can take away urges and cravings. The best way I can say it is I have a patient who's been on medication for 10 years, and he says to me every time, without this medication, I would not be able to be in recovery. He didn't say, without this medication, I wouldn't be normal. He said, without the medication, I would not be able to be successful in recovery. I think that's very powerful. So too often we've seen this debate. Is it A or is it B? Is it all abstinence or harm reduction? Is it medication assisted? And it's really all of these things. We have to have different ways of getting people better. The biggest tragedy I see in mental health and addiction right now is that we have treatments that work, but we don't have people accessing care simply and easily and available. And I think we can do a lot better with it. I have a lot more to say on that, but that's my number one principle. Medication works when it's used in combination with therapy, counseling, lifestyle changes, support, mentorship, and advocacy. When patients come into my office and say, I just want to take the buprenorphine and I don't want to come back, I don't want to do the work of recovery, I do not prescribe buprenorphine. We can only use medications when it's used in combination with the rest of the recovery toolbox. And vice versa. If they say, I only want to do 12-step, I don't want to use medications, and I'll say, but we need to look at extensively to see whether it will be helping or not. So I'm proud to say here at UCLA, I'm working in partnership with a lot of members in the community. We work with a number of other residential programs. We work with places like Connections in Recovery and Milestones Malibu Ranch, Creative Care, Betshuva. So we're really partnering with the community, academics, community, nonprofit, community advocates, and all the men and women in 12-step to really have a seamless field where we're all working together. Let me pause right there and looking forward to more of the debates and questions, and happy to answer more questions as it comes along.
Thank you so much, Dr. Fong, for that statement. Moving right along, Lowell, we would love to get your take on our exciting topic today. Without further ado, please.
Thank you, JD. I appreciate your introduction to this discussion. And Dr. Fong, you have a lot of great things to say. I really appreciated your introduction to your position on this. I'm really looking forward to hearing Heather. I appreciate the opportunity to be on this panel with all three of you. You just seem like amazing people. And my position on sobriety is really that sobriety is defined as a soundness of mind free from reliance upon mind or mood altering substances. This type of sobriety comes from creating or recreating, in my estimation, a reality-based, unadulterated connection to life that allows one to be fully present, in a word, abstinence. In my experience of the last 31 years of working with alcoholics and addicts, it's imperative to be able to address the underlying causes and conditions as opposed to trying to address the symptoms. I think so often it's easy to fall into the trap of this person is having a problem with cocaine, they're having a problem with alcohol, they're having a problem with heroin, and address the use of that substance. But I think that leaves on the table the fact that what we're really driven by is selfishness, self-centeredness. We're unable to really find our way in the world. We don't feel like we're a part of. And eradicating that alleviates the need for the substance of our choice. And in the 12 steps, the admission of powerlessness over our substance of choice is merely the price of admission. That's the first of the 12 steps. The rest of the work takes place dealing with how we've been living our lives. You know, the fact that we've been driven by 100 forms of fear, self-delusion, and self-seeking, addressing that is what gives us relief. And if I can't find the relief that I used to get from the alcohol and drugs, I guarantee I'm going to go back to it, or I'm going to put a bullet in my brain. It's really that black and white for me. Now, when it comes to Medicaid-assisted treatment or harm reduction, you know, if a person can be prevented from having an overdose by using buprenorphine, by all means, use the buprenorphine until you can get stabilized and get to a position where you can actually start addressing some of the other issues. If a person overdoses, use as many doses of Narcan as are necessary to revive that person. You know, there's a reason why those chemicals exist. If Vivitrol or Antabuse can give an alcoholic pause and prevent them from picking up a drink and relapsing or committing suicide, by all means, you know, Vivitrol or Antabuse, whatever is available should be used. And same with antidepressants. If people are spinning out of control and are going to die as a result of their disease, whatever chemicals it takes to straighten out the brain chemistry should be used. I don't think that harm reduction or Medicaid-assisted treatment really needs to be an exclusive. As Dr. Fong said, I think that the two can coexist. I just find that it's hard for recovery to take place from those underlying causes and conditions when I'm blocked off from being able to make an emotional connection with the reality of my life, emotional connection with the people around me, and emotional connection with whatever that power is that unites everything in this world. And my fear is that Medicaid-assisted treatment is going to become the methadone of the modern era, where what was designed as an adjunct to recovery therapies becomes the modality of treatment. Instead of the buprenorphine being a part of trying to stabilize a person and get them deeper into recovery and hopefully abstinence so that they can live chemical-free without relying upon a substance. You know, what happened with methadone is now you've got methadone treatments that are just doling out methadone. My fear is instead of dealing with the real underlying causes and conditions, which may come as a result of the 12 steps, it may come as a result of therapy with whatever modalities is working for the individual. But unless that's addressed, I feel like the recidivism rate is going to go on no matter what. I think that, you know, I deal with the 60 to 80% of the people that have failed. You know, at any given time, the people that are coming to us have been through 5, 10, 20 and more treatment attempts where they've used methadone as the solution. They've used Suboxone as the solution. They've used Vivitrol as the solution. And those solutions just don't work. They don't give a long-term sustainable method of being able to separate yourself from the chemical of choice. The people that come in here, a guy by the name of Sam came in and he had been in treatment centers where he'd been given Suboxone, he'd been given methadone, he was on Vivitrol, he was at the end of his last shot of Vivitrol. He told us that he needed to go get another prescription and get another shot. We told him, you know what, until you address the underlying causes and conditions, it's really not going to matter. You're going to relapse. You're going to go back to the relief that you know how to get. And he, instead of taking the shot, took the steps. And at the end of that process was able to stay sober. He's been trying to get sober for 7+ years. He's been to over 5 treatment centers before seeing us. And he just popped in the other day and picked up a 2-year coin to celebrate his continuous sobriety for the last 2 years. To me, that is a big victory, a big victory. He didn't have a chance at staying sober before he came to us. There's a lot of amazing people that are working in this industry, and I think I'm on screen with 3 of them right now. And there's a lot of great work that's being done. But from my estimation, I think that the treatment of the symptoms has become the dominant factor. Can we get rid of people's opioid addiction by giving them a new substance? To me, treating chemical dependency with another chemical just doesn't make sense. You know, if I was to ask the treatment industry as a whole to make some changes that I thought would improve the efficacy of what was going on, I would ask that we pivot back to what used to be the initial modality that was being used by the Hazeltons and the forerunners in the treatment industry, which was spiritual based, which was 12-step based. Teach people how to become a sponsor, how to find a sponsor, how to find a design for living that's going to give them long-term relief from the underlying causes and conditions rather than treating the symptoms of the use of the substance. And if we could separate insurance from, and what we've done here is we don't take insurance, separate insurance and the requirements of insurance and do what seems to be working. You know, we've found a very high rate of success. People that have attempted 10, 20 times are staying sober for long periods of time. I think that's enough. I mean, that covers your initial questions, JD, and I'm really excited to hear what Heather has to say and get into the Q&A. I think this is going to be a really great discussion. I'm really pleased, tickled pink to be a part of it.
Thank you so much, Lowell. That was very insightful, and you were articulate, and it's exciting to hear the different positions, and I could tell this is going to be very spirited. Heather, without further ado, last but not least, please, we would love to hear your take on this and your position.
Thank you. It's an honor to be here, and I'm just grateful to be here with so many with so many great colleagues. And I think what's so important is that we're even having this discussion. Sorry about the dog in the background. Charge. You know, what's important about this discussion is that, you know, we begin to take a look from the beginning of what does recovery mean? What is MAT? What is harm reduction? For me, I started my own recovery began in 1982. I began working in the field in 1983. And I have seen a lot of changes, a lot of shifts. And one of the things that you asked was that I define recovery. And to me, recovery means, you know, it's a very multifaceted answer. It is freedom from the cravings, freedom from drug use, freedom from, you know, having a compulsion that drives you, but it also includes connection and being able to look at the underlying issues and developing new coping skills. We know that there is a high correlation between trauma and addiction. And it's being in a position where you also have the ability to heal from those traumas. So it has to be looked at from that biopsychosocial, holistic place where we're really coming in and evaluating, has a person's functioning increased? Is their quality of life better? Ultimately, are they really able to deal with those existential issues of, you know, how do you make meaning out of your life? What is your purpose? Are you living a life where you feel better and those around you are in a better, you know, your relationships are better and you're no longer causing harm to others, you know, or to yourself? So I think you have to take all of those into consideration and also look at the fact that we live in a very different time than we've ever lived in. We live in a time where the landscape is that we're filled with contaminated drugs. We have 197 people dying of overdoses from opiates a day. In New York City, there was a study recently that showed that 40% of all cocaine deaths were from contaminated cocaine. 50% of those deaths, the individuals did not meet the criteria for substance use disorder. So we have a bigger systemic issue going on here. we have treatment out there that's fraught with fraud. We have treatment where we've got patient brokering, insurance fraud, and we even have some of our prescribers of buprenorphine who are being arrested for insurance fraud. So again, there's a bigger overhaul that needs to be done with how we're doing things. And we're in a different time, and the old school life lessons of let a person go out, bottom out, learn their lesson can mean death, and can mean death quickly. So we really have to step back, I believe, and take a look ethically and medically at the options that we're giving patients. We need to come in and, Dr. Fong, I really love what you said because it really aligns with my belief, which is that if we come in and determine due to history, due to risk, that a client will benefit from buprenorphine. And by the way, there's a way in which we need to define our semantics too, because MAT sometimes gets hooked with meaning buprenorphine, and it doesn't. It can mean Vivitrol, it can mean Cymbalta, it can mean antidepressants, it can mean naltrexone. But if we have clients that are going to be on buprenorphine, for example, that we also come in and put in other protective measures, that we're making sure that they're not using other medications or illicit drugs that might put them in danger, that we're coming in and giving them other protective measures, like, again, ways to learn new coping skills, ways to learn how to connect better, ways to learn vocational skills so that they're able to take better care of themselves. So it's a much bigger systemic issue. Harm reduction is something that we practice in our lives every day. Harm reduction saves lives. It changed the way it turned the tides for AIDS when we began to practice harm reduction with needle exchange. We're all practicing harm reduction now. We wear masks, we wear our seatbelts. So what's important is also looking at the bigger picture. We've got our clients with substance use disorder, and none of them should leave treatment without ethically knowing what the options are for them as far as medical assistant treatment to help with cravings. Every client who has an opiate use disorder should also leave with naltrexone because of that 90% relapse rate. But the bigger picture too is we've got to come in and educate our communities about the dangers. I mean, again, I've had clients, colleagues who've had 15-year-olds who've overdosed, and it's only the second time they've used a drug. And today our teens are going straight to heroin, or they're using contaminated cocaine, other options. So it's very, very dangerous. And I've said, I have a talk that I give where I talk about how we need to really look from a bigger picture at what we're even teaching prevention-wide for our children. So we come in and we teach our children, we have, fire drills, tornado drills, active shooter drills in elementary schools. And we've got to begin teaching addiction drills because that's far more likely to kill our children than a tornado or a fire. So I feel like we need to really all work together and not against each other. Whether you believe in medically assisted treatment, or not, or how you use it, doesn't mean that you don't want people to live. And we need to all pull together to see how we can be better at what we're doing and look at our clients and look at our country and see where they're at and how do we help. And what do we do with a client who comes in, who is a war veteran, who has horrible PTSD and is shooting up 30 times a month and is overdosed 4 times in the last month and comes to us and says, I don't want to use IV drugs anymore, but I'm not ready to give up the marijuana. I'm not ready to give up the alcohol. Are we going to help them? How can we not? So again, I think we also need to look at and evaluate how we measure success in treatment and how we measure success in recovery, and really taking a look at and valuing more incremental improvement instead of quick, drastic improvement. Thank you.
Thank you so much, Heather. That was beautiful. And before we move on to the next phase, just to summarize, we've heard really, really succinctly and beautifully from Dr. Fong and from Lowell and from Heather is how timely, how relevant, and how crucial it is to really be at the forefront of this type of life-saving treatment. And, Lowell brought up a very interesting point, which I'm sure the others will have a chance to explore and question, and that is the medication-assisted treatment. If it is some type of a mind-altering chemical while they're utilizing that medication, how will they be able to tap into the necessary emotional depth and alacrity to really undergo the transformative type of change that usually occurs in a residential rehab facility, if I was understanding you correctly, Lowell? Heather, was so nice to hear from you about trying to bridge the gaps between the medication-assisted treatment, and that was something that Dr. Fong mentioned as well, about trying to see the synergy and potential harmonious relationship between the two of them. I would love to hear more about that as well. And without further ado, we're going to give each of our participants a chance to ask a person of their choice a question. And Dr. Fong, why don't you lead? Why don't you choose one of the members of our panel with this question?
I could spend all day with everyone here, but I'll ask Lowell this because it ties on to that. How do you know when someone is emotionally blocked off from medication? Because in my world, if they're emotionally blocked off, or they're numb, if they're not feeling things, that's not a treatment success. That's a side effect, or that's over medication, and that's an inappropriate prescription. So how do you know in the recovery world, Lowell, that someone is not emotionally available when they're on medication?
I thank you for that question. I really appreciate that. And I'm not an expert at medication. I'm not a doctor, so I don't try to get into when somebody's over-medicated or not. I don't really gauge what medications people are on. But here's my experience. Over the course of doing hundreds of fifth steps, the people that are not on medication will have an emotional or visceral response. And that's the point at which people start to realize that the way they've been living their life is really the problem. And they become willing, as a result of looking at that, to find a new way of living. So they're not showing up the way that they have. And in my experience, people that are on heavy antidepressants or buprenorphine, they're not present. They're not able to make that connection. They don't seem to have that visceral or emotional response that's required to really realize what's been transpiring. Alcoholics and addicts, in my experience, are adept at delusion. We convince ourselves that the problems that have transpired in our lives, and it doesn't matter what background we come from, that becomes the narrative that justifies our behavior. And until that delusion can be broken through, the rest of the work that has to be done can't take place. And to be honest with you, I can't really define emphatically what the break point is between being emotionally available and not being emotionally available is. I just know that I have better luck with people that are not on drugs that suppress their emotional availability. Does that make sense?
So now the way the format of our discussion is going to be, Dr. Fong will have a chance to respond to your point, and then Lowell, you'll have a chance to respond to Dr. Fong. So without further ado, Dr. Fong,
Right.
What would your response be to that?
Oh, yeah. What I say to patients is that I say medications lay the groundwork for recovery. And if medications are proper for you, you'll be able to pay more attention, more attentive, concentrate better, and feel more. So that's actually in tune with what we're saying here. I think this is a perfect example where we need that synergy between 12-step and recovery and industry and medicine and psychiatrists. Because I would love to hear more feedback from people in the room or from therapists who say, I believe my client is just not emotionally there. Because absolutely, when medications are too much, they numb everyone. And that's not treatment. That's numbing. That's intoxication. That's a side effect. It's not appropriate. So I absolutely agree with you. But I think our systems are not set up. The way they go is I give a medication, people run off for 30 days and they never come back. That has to change. So the idea now in this new world is I give a medication, I have to get more feedback throughout the month about what's happening, what they're doing, how are they participating. I want to hear from the sponsor. I want to hear from family members. And I think that's been our biggest shift. That for years, we would never do that. We would operate recovery in isolation. We can't do that. We have to operate recovery as a community where all of us are constantly in dialogue with one another rather than just, have all these split lanes.
Thank you. Thank you, Dr. Fong. Lowell, do you have any response to that?
Sure. Dr. Fong, I agree with you that we all need to work together. Like I said, when I shared, it's not an adversarial or an and or. It's, there's no reason why people's lives can't be saved by harm reduction and medication-assisted treatment. My fear is what's going to happen is it's going to shift. And I saw a mandate that was passed out by SAMHSA that now is going to dictate that MAT be changed to mood, medication opioid use disorder treatment, identifying the Suboxone or buprenorphine as the primary source of treatment. And that's where I think that we go off a precipice, because as Dr. Fong said, people come in, they pick up their medication, they go back out about their merry way, and never does the underlying causes and conditions have a chance to be eradicated, addressed, or find another form of relief for, because the medication is providing that relief. Does that make sense? I'll stop saying that after that time.
Yeah, you open a can of worms when you ask if that makes sense. But thank you so much for that. And now, Lowell, why don't you ask one of our participants and a person of your choice a question based on the position statements that we just heard?
Can it be a personal question?
Most definitely.
I'd like to direct my question then to Heather. Heather, when you got sober in the early 80s or clean or whatever, you said that you got into recovery. What did that recovery look like? You had mentioned there's been a lot of transformations back in the early 80s. There was a big preponderance towards healing the child within. There was a lot of different things that were going on, but I felt like most of the treatment in the early 80s was more 12-step based. And I'd just be curious to hear from you what your personal experience has been with getting and staying clean and sober or in recovery, and what you've seen in terms of the changes of the modalities that are being presented today.
Thanks. Yeah, I love talking about my recovery because it's such a gift, and I wouldn't have anything I have today if it weren't for my recovery. And when I went into treatment in 1982, from the beginning, things were different. I was 21 years old. I was a college student, and I went into treatment, and the program that was available to me at the time was a program that treated addicted physicians. So I was the youngest one there. I wasn't a physician. I was I felt like a duck out of water. I had a great list going of every reason why I couldn't relate to everyone around me. So I think one of the first places that I would even start with what's different is the fact that we now even have age appropriate treatment. We have treatment that looks at the developmental needs of young adults, college students versus 40, 50-year-olds or persons with their own careers. The blessing for me was that I did end up in a treatment facility that was run by a man at the time who ended up having his own facility. His name was Dr. Douglas Talbot. And he was one of the pioneers of talking about addiction being a disease and a medical disorder. So I came into treatment having studied psychology in hopes that would help me figure things out. And also thinking I was half crazy. So there was some relief in that. But the treatment that I had, it was very 12-step, and I loved the 12-step programs, and I'm still an active member. But it also didn't do a lot to address, as a woman, my own personal shame, my low self-esteem. In fact, the type of treatment was very shaming. There was kind of a belief of building people down and helping them to and having them build back up. It was extraordinarily confrontational, which was not necessarily what I needed at the time. I'm here. It worked. It helped me to understand that there were things I needed to do to save my life. And that part was helpful. But over time, I'd seen the care change and become more compassionate, really address more of the underlying issues where that treatment is therapeutic, looking at attachment disorder, trauma, and the 12-step part of it becoming more of the icing on the cake of the treatment, not the cake of treatment, but introducing people to another life, to that support group once you leave. I also think there have been a lot of changes in how we handle work with the family systems, parents, children of people who are addicted, and that's all grown in a lot of positive ways. Initially, I believe, we started out the whole focus was on the person with the addiction, and the family didn't get as much attention, even though they didn't get to black out and they had to live on the other end of our behaviors. So there are a lot of ways that things have grown and changed. Even back when I was in treatment, you couldn't take a Benadryl if you'd gotten stung by a bee without checking with your addictionologist. There was, for me, some merit in that. But the fact that we now have and can look at ways in which medication is helpful and appropriate, I think is important. And look at ways in which the pendulum swung. Back in the 80s, we would also do a lot of treatment that would open people wide up and then send them home when they were emotionally raw and not ready and didn't have the coping skills to deal with having someone deal with trauma that maybe they weren't ready to deal with. So I think we've become more finessed, and we've really been able to really look at what's worked and what hasn't.
Thank you so much for that, Heather. Lowell, is there anything you'd like to respond to that?
You bet. Heather, I was anxious to hear your experience, and it mirrored what I'd expected. You did make a comment about the 12 steps being the icing on the cake and all the other work being the primary focus. And I think that that's and this is just my opinion, one of the problems with treatment today is that in order to get insurance coverage, one has to be diagnosed as depressive, suffering from anxiety disorder, whatever, bipolar, and then that gets treated. And then as an adjunct to that, I feel like the substance use gets addressed, the icing being the addressing of that issue. And I feel like in my experience, the trauma, the various things that have transpired in my life are my excuses to continue acting the way that I act, and drinking and using the way that I drink and use. So I appreciated your wisdom and your insight, but I feel like the industry has shifted to where it's mental health based and addiction secondary. And I feel like if the person that is suffering from the substance use disorder is given a year for the brain chemistry to balance out and can use the coping mechanisms that are existing within the 12 steps, at a year of sobriety, a year of clean time, and once their brain has kind of gotten back to a stasis, then they can look at what else is really going on. And I feel like as an industry, that's been reversed. Now, maybe that's my naivete, but that's been my experience.
Thank you so much for that, Lowell. And moving along, Heather, your turn. Who would you like to ask a question to, and what would that question be?
So I would like to ask the question to Dr. Fong. And I would just like to hear you expand a little more about one of the things that you said that I really like is, I believe that when using medicated assisted therapy, that we have to have other protective measures in there, other treatments. I've had clients where they had no opiate use history, young adults, who 7 months into their recovery have convinced a doctor they need to go on Suboxone. Now, we know that there are places where even, medications like Subutex, Suboxone, buprenorphine can be abused. So what kind of protective measures do you feel are important in working with someone, again, who is on medicated assisted, MAT, medication assisted therapy? And also, could you speak to another issue that I find very problematic, which is the use of Adderall and other amphetamines as a MAT, particularly with clients who've had a history of methamphetamine or amphetamine abuse?
Thank you, Heather. Those are great questions. And those are questions I get all the time. I think it starts with, again, understanding kind of the physician perspective. We have about like 900,000 physicians in the United States right now. The vast majority of them are not specialized in addiction medicine or addiction psychiatry. In fact, there's only about 3,500 of those addiction specialists. So when you go to medical school, the amount of training and education you get in addiction is infinitesimal. It's very, very small. And it starts with addicts are bad, men and women with addiction, you should hit rock bottom. And even now in 2021, we still see that a lot in education. Combine that with a lot of this idea when it's taught in psychiatry that psychiatric medications are good and you should treat signs and symptoms. You create this generation now over the last 30, 40 years but physicians who are eager to try and solve human problems with pills, who are eager to solve problems by, listening to patients say, hey, can you do this for me? Because my friend get it, can you do that for me? So I think the number one area, at least that we've been working on, I really firmly believe, is much better education of physicians about the power and potency of the medications we prescribe, as well as the power and potency of substances out there. We really need to do more. And so many physicians never go attend a 12-step meeting. So many physicians have never set foot inside of a credible science-based residential treatment program. They don't know what happens in there. So when it goes to those protections, if we're going to have controlled substances that are prescribed by physicians, we have to have physicians who are better educated understanding addiction. And we have to come down much harder on physicians that overprescribe, much harder on physicians that don't do it correctly. Just as I would not prescribe chemotherapy for cancer. It is not my wheelhouse. Unfortunately, there are many doctors who do prescribe the Adderall, the Suboxone, the buprenorphine, and even the methadone because they think that is a, quote, right thing to do. Our nation is severely lacking in that area. And again, you can go through residency, you can go through medical school and get less than a few hours of training in addiction, understanding psychiatry. I think that's really, really wrong. Number two, I think in my career, just in the last 20 years, we've seen really rapid advances in medication for addiction. And I think we will have more and more, but we need to do better. And again, by better, what I mean by that, we have to have prescribing systems that are also doing it in co-occurrence, but also with other people who understand addiction and recovery really well. We actually had a clinical trial looking at Adderall a few years ago for the treatment of methamphetamine use disorder. Under that idea, would it be similar? It just didn't work. It bombed out. No one got better. But what we don't do is we don't advertise and tell the community when scientific trials fail. We don't say enough about we tried this and it didn't work. We tried over 30 different medications for methamphetamine. Nothing has worked. So maybe we need to try something else. Maybe that's an addiction where medications don't work. But we rarely tell people there's been trials that just didn't work because you don't get grants, you don't make money, you don't advance in academia for publishing articles that say something doesn't work. So the long and short of it, the protections have to start with, at least from what I see, better education in physicians. And then number two, patients and families have to better understand what they're getting in for. And I don't think they have that enough. When patients Google right now medications for addiction, they get quartered off to a million different places. And the disinformation and misinformation is so incorrect. We have to do better about having credible sources where patients can learn about medications in a proper way, what's myth, what's false, what's fiction, versus what's actually scientifically true.
Thank you so much, Dr. Fong. Heather, do you have a response? Would you like to respond to Dr. Fong's answer?
I really appreciate what you said. I think you're right. The minute our clients get on the internet, we've lost them because there's so much out there. I really like your cancer analogy because I was thinking about that in relationship to MAT as well. And, I've seen physicians who prescribe buprenorphine, for example, and then don't do any other follow-up, don't make sure the person's not taking benzos, has the right coping skills. And to me, that's as unethical as if you had an oncologist who did chemotherapy, but then didn't check blood work, didn't do scans to make sure they were better, weren't really looking at the progress and making sure that their clients were well taken care of. And even bringing in, the social worker to help work with the family who's suffering because of their patient's illness. So thank you for what you shared. I agree. We've fought hard to have addiction considered the illness that it is. And I think that we have to continue to push to have it treated that way in our medical schools and across the board so that our clients and their families who are so vulnerable to wanting a quick fix or wanting to, who are desperate to get better aren't taken advantage of. So thank you.
Thank you. Dr. Fong, any response to that?
No, I think that's very well said. Again, I think you're hearing the common themes that all of us have. I mean, I learned so much. I learned more about treating men and women with addiction from my patients, but also from spending time in places like Betty Ford and Bathsheba, and meeting men and women like Lowell and Heather at addiction recovery conferences. That's where I learned so much more than from the textbook or from the conferences I went to, on the science side. It really is that humanism of recovery. And I think that's the theme we all speak of. Finding connection, finding that spirituality, finding that we're really a lot more alike than we are different. I think that's so incredibly potent.
That's beautiful. And I would just like to highlight the fact that that's not necessarily common amongst all the physicians treating addiction. So may there be many more Dr. Fongs in this country, many people who emulate that path and not necessarily locking oneself in the academic and the research and in the hospital, but also venturing out into the recovery culture, into the community, and into the AA meetings. We've now reached the next phase of our program. Very exciting. I would like to take this opportunity to ask each and every one of you some questions regarding your position and regarding your statements. Let me start with Dr. Fong. So Dr. Fong, they say God's in the details or the devil's in the details, but the details ultimately matter, whichever way you phrase it. How long would you prescribe the process, the treatment of medication-assisted treatment to last for? What would be your ideal scenario? How long should it take for the client, for the individual to be able to kick it? Is it a month? Is it 6 months? Is it a year? Or is it 5 years? Or is it ongoing? And that's the first prong, I guess, to the question. And the second prong of my question would be, is there any scenario, is there any type of situation in which you would advocate first and foremost for alternative interventions before introducing medication-assisted treatment? Is there a case where somebody's coming, they've never tried anything else, they might not be a severe addict, their dependency might not be absolutely debilitating, they might be a weekend drinker but a consistent one, they might be a cocaine user but having it partially under control. Is there any type of situation where you would say, you know what, let's put Matt on hold for now and let's try an alternative, whether it's therapeutically or whether spiritually, holistically, let's give something else a shot first?
Yeah. I'll answer that second question. That happens all the time. Patients come in and they expect to leave with a prescription. And oftentimes I don't give them. I say, no, you need to do the 4 principles of recovery: home, health, purpose, community. You need to do 90 meetings in 90 days. You need to participate in AA. That doesn't mean just watching a Zoom. That means getting a sponsor, having a commitment. So every patient that comes in gets an individualized treatment plan. It's never the same. And I think that's so critical. Some, of course, absolutely, we're going to start medication on the first visit. Others, I just won't give. I'll say, it's not going to help you. It's going to make you worse. When patients say to me all the time, how long do I need to be on medications for addictive disorders? I'll say, not 1 minute longer than you actually need. So for some, I've had now some patients on for 15 years with medication. I've had others who were on it for a month and then they were able to stop. Again, that's part of the art and the science of addiction psychiatry. It's continually meeting with patients and determining what is the proper dose, how long should you be on, are you numbed out in meeting, are you advancing in those domains of recovery, home, health, purpose, community, are you treating the underlying cause that Lowell highlights so well, the co-occurring disorder or the issues with your personality that you haven't figured out. So those are the themes that we work on. And so ideally, one of the things I really don't like is when we have these algorithms that say, put a patient on 14 days, then after 3 months, get them off, then after 6 months, do this. Or worse, I can't imagine going into a doctor's office and a doctor saying to me, you need to be on this medication for the rest of your natural life. And if you don't, there's a chance you could die. Now, there's 2 cliches here I hear a lot. People say, well, you can't recover when you're dead. And I hear that, and I don't know if I really like that. It's just so dramatic. But I also think more about like diabetes. There are a lot of men and women who get started on insulin and seemingly they think they need to be on insulin for the rest of their natural life. But when they make changes, when they correct the underlying problem, maybe it was a lack of exercise, maybe their diet was terrible, maybe it was just stress, that oftentimes they can go off insulin when they thought they were going to be on insulin forever. I think it's the same way with addiction and the same way with medication for addiction. And I wish we could get rid of the term medication-assisted treatment. There's been an advocate, well, why don't you call it treatment-assisted medication? I think that's wrong too. It should just be treatment. It should just be treatment for addictive disorders. And like when you go into a Jiffy Lube, you get 1,000 different options and 1,000 different ways to get your car running smoother. It's the same way with addiction. It should be one part, but it should not be mandated, and it should not be summarily dismissed from that treatment menu. It is part of that treatment recovery roadmap, but is not the end all be all. That's how I view it.
Thank you so much for that, Dr. Fong. That was very insightful. Lowell, I want to ask you a question or two as well. So, what some critics might say to the total abstinence approach and to that model being front and center of what we're advocating in treatment centers and not necessarily giving a lot of spotlight to medication-assisted treatment, what happens when somebody has been in treatment for 3, 4, 7 times, 11 times, and every time they relapse, every time they leave against medical advice, there's a very real, tangible chance that they're going to die, that they're going to go overdose. And so how would you respond to some critics who might say that this approach of really favoring total abstinence might be choosing quality of sobriety over quantity of life? And in that response, I guess the second prong would be, how would you determine when it might be appropriate for medication-assisted treatment to come into the play? When would it be appropriate to introduce that, if you feel that it would be appropriate? What criteria would you utilize?
I'll answer those in reverse order because I've already forgotten the first question. I'm sure it'll come to me as I answer the second one. I don't prescribe medication-assisted treatment because I'm not a doctor. I don't have the expertise that would be necessary. I can differentiate between an alcoholic and a non-alcoholic, an addict and a non-addict. I can use the tools that we implement to treat that. But I cannot treat bipolar disorder. I cannot treat schizophrenia. The 12 steps do not have any effect on those. In terms of people relapsing and dying, I don't ask people to come here and then leave and good luck. I don't give them a prescription that they need to follow up with at a pharmacy. What we offer is an opportunity to start developing a set of principles that are applied uniformly in our lives, creates the cessation of the need for the substance. You know, my problem is not my substance use. My problem is that I'm insecure, I'm riddled with fear, I'm delusional, I blame other people and situations for my circumstances when they have nothing to do with it. And if you're really living in the 12 steps, not just reading them on the wall, but you're actually integrating them into your life, what transpires is a relief from the need for the consumption of the substance. And when people leave here, my hope is what they will have done will be to have begun to integrate that process in their lives and be able to maintain relief from what has been plaguing them up until the point where they got to the point where they were able to address that. And one thing, if I can, on Dr. Fong's comment, you know, I was recently discovered that I have coronary problems. I have to have a quadruple bypass. I went into the doctor's office today, just before this seminar, and I listened to what the doctor told me I had to do, and I'm going to do what that doctor says. And I think with addiction, when a person that has addiction or alcoholism, they go to a doctor that, as Dr. Fong has mentioned, who's been through their residency, has been through their entire education, has had maybe a couple of credit hours or maybe a couple of hours period in education about this. And when they hand me a prescription for Vivitrol, they hand me a prescription for buprenorphine, they hand me a prescription for whatever, I have to accept at face value that that's the solution. And if they suffer from the same disease that I do, it's not. The solution has to be finding a new way of living, because the way that we've been living up to this point has been uncomfortable enough that we have to consume substances in order to feel comfortable in our own skin. And eventually the problems of consuming those substances become greater than the problems that are being solved. And I'm going to say it one last time. Does that make sense?
Thank you for that, Lowell. Lastly, I will turn to Heather. And Heather, I've got a different type of a question for you. We live in the year 2021. you've been doing interventions for a very long time. You know, if somebody would have told you 5 years ago that the only thing about a family getting together and smoking weed, the only thing illegal about that is the family getting together, we would have written them off and said that you're crazy. But in certain parts of the country, that's our reality today. And I want to know if your interventions have evolved based on the climate changes, based on the different natures and maybe some different origins into the chemical dependency, and what our youth are currently struggling with.
So thank you. That's a great question. And often, I mean, I would probably say I have to have the pot is organic argument with a young adult at least once a week. If I'm not, something's not going right. So my experience over the last 10 years or so is that we are seeing much more mental illness. And we're also seeing a lot of issues secondary to the marijuana of today. The marijuana today, we all know, is far more toxic, far more potent. And I was thinking about this as Noel was speaking as well, about having that ability to come into treatment and clear up and get that aha moment, which I think is important. And I think it's really difficult. Our kids' brains today, you know, our children, the average first age of use is 12, but we're seeing kids who've started using at 6, 7. We have screens, which are a whole new issue. Like, we have no idea what kids growing up with screens in their face, you know, from 6 months on is doing to brain chemistry and how the brains are forming. We also have drugs that our kids are using today that come off the dark web that don't even have names. They're all letters and numbers, and they're hallucinogenics. So our children's brains are being insulted before they've even had an opportunity to grow and mature. So I'm seeing much more psychotic breaks, much more psychosis, much more drug-induced psychosis. I'm seeing many more family systems that struggle with the whole complexity of, we use drugs in the 70s, why is it not okay for our kids? And again, I think we have to back up and take a look at educating our children, educating our families, educating society on what are the signs and symptoms? How do you know if someone's in trouble? And those discussions need to happen at the dining room table at home with family dinners, which there's a statement right there, having family dinners. But having our parents talk to their kids, learn themselves, teach our children that if you have addiction, it's hear what the signs or symptoms are, and it's not a disgrace, and it's not a disgrace to ask for help. And to also educate around what our children are faced with today, which again is a world full of contaminated drugs. You better believe that if tonight on the nightly news an announcement was made that a majority of the alcohol in the country had been poisoned with fentanyl, we wouldn't just come in and say, gee, I hope it gets better. It would be all over the news. Every bar you were at would probably have strips to test the alcohol to make sure it wasn't toxic and poisonous. And so again, we've got layers upon layers of problems. We have children who are using drugs and alcohol for the first time. And in that, they're getting something that's been contaminated. And so it's a whole different landscape than we had before.
Thank you. Thank you so much for that, Heather. So I want to conclude by sharing with you a beautiful story that's a well-known story. And then I do want to say that we're getting so many amazing questions from our live audience. Unfortunately, we don't really have time to take them, but actually we'll take one question. That's for Dr. Fong. Will you create a CME Institute for all physicians post-medical school?
Someone's got to support and pay for that, but yeah, no, we actually, we almost had an institute, an addiction training institute for that a few years ago. In fact, I am working right now with Betshuva, the Elaine Breslow Institute, for that very purpose, for us to try and improve medical healthcare education of first responders for addiction, not just doctors, but nurses and policemen and firefighters. And I just want to echo last thing what Heather said. If I said to you, there's substances coming into America that will kill 80,000 Americans every year, that's chemical warfare. There would be marches on Washington. There would be calls for massive mobilization, like what we're finally seeing with COVID. We still haven't seen that. So we haven't yet, and hopefully that's part of it, organize ourselves to advocate loudly and a unified force to not only get these contaminants off our street, but improve living conditions for children, men and women who are struggling with all those things that we see, whether it's racism or poverty and whatnot, that then turn to substances. So we have so much more work to do, and I think we will be able to get that done.
That's very, very true and very poignant. Lowell, do you have any final comment that you'd like to make before we move into the conclusion segment?
You know, my only comment is I wish there was more Dr. Fongs in the world that could help to craft a more comprehensive perception of recovery. I feel like this panel has been super productive, and I really just appreciate being a part of it. I want to thank you for inviting me. And Heather, thank you very much. It was great to meet you and see another person that's fully engaged in recovery. I really relish this opportunity. Thank you.
Thank you for joining us, Lowell. And Heather, any last comment before we go into the conclusion?
Absolutely. What I would end on is to say that we really are at battle, at war with addiction. And it's important that we pull together, that we combine all the resources that we've got so that we're able to really move forward and fight what I consider our biggest terrorist addiction. And that we do that, and that we don't split hairs fighting amongst ourselves and each other over terminology. You know, there are a lot of lives that we need to save. There's a lot we can do there's a lot we can do for prevention. There's a lot we can do in education. There's just a lot we need to do. So again, I hope that everyone will put their best foot forward. There are a lot of very ethical providers out there who are working tirelessly to help support each other and to fight this battle. And we need to quit fighting amongst ourselves and pool together and fight addiction.
So true, so true. And Dr. Fong, a final comment from you?
Absolutely. For anyone who wants to learn more about medication-assisted treatment, how it's being done in a proper scientific way, take a look at our professional society, the American Academy of Addiction Psychiatry. I'm actually the treasurer of it. It's a group of about 3,000 addiction psychiatrists that are really looking for how to do this properly. And we love it when we have as many members from the recovery field come join us at our annual meetings and come talk to us about the stories that we see. But again, I'll just leave it. The glass is half full. We can do so much more. We've done so much more. And people oftentimes say to me, how do you continue to do the work you do? It must have a drain on you. And I said, it's hard. But again, when treatment works, when recovery works, it's spectacular and is nothing short of earth moving and inspirational. I think all four of us would echo that sentiment. Absolutely.
Most definitely. And it really reminds me of the story of the young boy who was walking along the beach at sunset, and a fellow sees him picking things up from the ground and throwing them into the water. And it's a well-known story, and the man comes even closer to him, and he sees that he's actually picking up starfish that had been washed onto the beach. And he asks the boy, what are you doing? And the boy says, I'm throwing these starfish back into the ocean because they will lack oxygen and they might die. And the fellow turns to him and he says, there are thousands of starfish on the beach. There are thousands of beaches on the coast. You can't possibly make a difference. And the boy smiled and he bends down and picks up another one and throws it back into the sea and says, well, it sure made a huge difference to that one. And that is something that if we can walk away from this panel, from this program, more educated, more enlightened, and with some insight that could even save somebody in our circle, in our sphere of influence, then all our efforts will have been worthwhile. And I want to really thank our participants, our illustrious participants, for joining us today, Dr. Fong, Lowell, and Heather. And thank all of you for joining us today, in which we hope will be an ongoing conversation about really reconciling so much of what we spoke about. And We invite you to share your comments and continue the discussion online at Montare Behavioral Health Facebook page. Thank you so much for tuning in to this episode of the Discover You podcast, and looking forward to seeing you on the next one. Take care.